Hey, good afternoon, everyone, and welcome back to the channel, Appleberg Help for Docs, your source for Medicare risk adjustment, all things risk adjustment, coding, CDI, outpatient CDI, that is. And my name is Tony Appleberg Parks, and I am your educator in those and similar areas. So, today, what I'd like to talk about is if your practice has been billing G0136 for social determinants of health assessment, I need you to stop for a second because as of January 1st, 2026, that code does not mean what you might think it means anymore. So today we'll break it down exactly what changed, why CMS made the switch, and what it means for your documentation and bottom line. But first, we must keep the lawyers happy with our quick disclaimer. So remember, this is educational content. It's not legal or compliance advice for your specific situation, and everyone's situation is different. Coding rules do shift, and so please always confirm what you hear today against the current CMS, AHIMA, AAPC, and ACDIS guidance before you make any changes at your practice. Keep in mind you may be watching this video months or even years down the road, so things do change. Okay, with that out of the way, let's kind of set a baseline. G0136 launched back in 2024 as the SDOH risk assessment code. And the idea with that was to pay practitioners for identifying social barriers, things like food insecurity, housing instability, transportation gaps that were getting in the way of the patients following their treatment plans. And it wasn't supposed to be a screening that you ran on every person. It was for when you had a reason to believe something was interfering with this patient's care. And practices used it a lot, over 235,000 times in that first year alone. So north of $200 million in reimbursement. So that's a well-established workflow for a lot of you, right? This was the headline. Effective January 1st, 2026, CMS kept the G0136 code number, but it completely swapped what it measures. It used to be about social risk factors. Now it's about physical activity and nutrition. Same code, same time requirement, same 6-month frequency limit, but a totally different clinical target. If your intake forms, your EHR templates, your staff training still are pointing people towards the SDOH questions when they are selecting the G0136, now you have a mismatch between what you're documenting and what your code actually pays for. So why the change? So we need to understand the path here because it tells you how firmly CMS is committed to this new direction. In the proposed rule, CMS actually wanted to eliminate G0136 completely. And their argument was that the resource costs were already baked into E&M and behavioral health codes. But the commenters pushed back on this, and CMS made a compromise, landed on a middle ground, keep the code, but repointed entirely at physical activity and nutrition instead of social risk factors. So that was a deliberate policy choice. It wasn't a typo. So it's not, we can't be expecting this to revert next year. Now, all that said, it's not a total overhaul. Some of the operational guardrails carried straight over from the old definition. Is still time-based at 5 to 15 minutes, still limited to once every 6 months, and still meant for a known or suspected need rather than a blanket screening. And it still pays with the same set of visit types. The billing practitioner still has to be the one doing the follow-up, and cost sharing still applies unless you're pairing it with the annual wellness visit. So the shell of the rule is still very familiar. It's the clinical content inside that the shell that flipped. Okay, so lean into this. This is what I want you to hear. This code was used heavily under the old definition, over 235,000 times in its first year, more than $2 million in reimbursement. So that means that a lot of practices have real entrenched workflows built around SDOH questions. So the risk isn't that G0136 disappeared, but that your team keeps running on autopilot, okay? Same intake forms, same training, same documentation habits, while the code underneath them now means something completely different. So if your note says you assessed housing and transportation barriers, but you billed G0136, that note no longer supports the code you're billing. So you have a documentation to code mismatch, and that's not only exactly what auditors are trained to catch, but it's kind of what they're really going after this year and forward, is making sure that the documentation supports the code at the time that's used on the date of service. So you can see the issue there. Okay, so what can you do about this? First, you should get into your templates and order sets and pull out any SDOH specific language that's tied to G0136 and replace it with physical activity and nutrition prompts. The second thing is retrain whoever's actually collecting the information, because the questions change, not just the code definition on the paper. So third thing would be to go back and spot check your G0136 claims from this year and forward and make sure that the documentation actually matches the new descriptor. And then the fourth thing I would recommend is if you're still doing valuable SDOH work with your patients, don't stop, keep doing it. Just code it correctly with the appropriate Z codes instead of folding it into your G0136. Okay, so if you take one thing away from this talk, I'd like it to be this. The code G0136 did not change, but everything that it's supposed to measure did. And it wasn't a slow phase in. It was effective January 1st, 2026. So, December 31st to January 1st was a big jump. So if your documentation for 2026 still reads like an SDOH assessment, don't wait till the next quarter. Fix that today. Fix it right away. Okay, and as always, I wanted to provide you with the sources behind the information today, so that, I typically get my information from one source and then I cross-check that information. So that's how we end up with multiple sources. So oftentimes the first one on the list will be where I originally saw it. Not that it really matters, as long as it cross-checks, especially with your regulatory sources. So you can see here we have NCQA and Part B News, ICD-10 Monitor. These are good sources. So I'd like to give that information to you so that you can dig in deeper if you like. So there's that. And I try to always remember to put the links in the comments or in the video description as well. Okay, but they're not too hard to find if I failed to do that. Okay, and then I just want to invite you, if your team needs any help working through changes like this, or if you just have questions, whether it's about this or outpatient CDI, risk adjustment, auditing, other physician education in this realm, that's exactly what I do, and the best way to reach me is on the website through the contact form, helpfordocs.com. And also, I ask you, if you enjoyed the content, if the content is helpful to you, please give me the thumbs up and subscribe so that we can keep getting this information out there. That's my ultimate goal, is to try to help people understand all the things happening in this complex world, and try to explain it in a way that's a little, a little more simple than what you might see in the regulatory documents. So I hope that's helpful for you, and I do thank you and appreciate your time joining me today. And I'll see you on the next one.